So I think something that really showcases the reason why I think depression should be broken up and categorized into a bunch of different sort of subclasses is the treatment options for depression. So to understand the different ways that depression is treated, we're going to talk a little bit about the brain. So let's go on a little journey. But it really wouldn't be a very ADHD podcast if my ADHD brain didn't get distracted. So anyway, we're going on a side quest here.
Welcome to It's Just ADHD. We're two curious ADHD coaches, and we're going deep on the how, the why, and the strategies to get through the difficult moments and how to make the best of life with ADHD. I'm John, and I've got an adult diagnosis of ADHD.
And I'm Tarah, and I have a late in life ADHD diagnosis and an even later autism diagnosis. We're going to be diving headfirst into the messy and often complicated research around ADHD and autism. And we're bringing you along for the journey as we break it all down and make sense of everything.
Because sometimes it's just life.
And sometimes it's just ADHD.
Welcome back, friends. We're excited to bring you this short bonus episode, diving a little bit deeper into a topic we touched on last episode, depression and how ketamine works as a treatment. This is a fascinating area where science and mental health meet, and we didn't want to leave it out because we think it's pretty valuable. So today, Tarah is going to take the lead, sharing her expertise and breaking down the details for you. So settle in for this quick but enlightening exploration. We hope you find it as intriguing and informative as we have. All right. Take it away, Tarah.
So before we begin, I just want to remind you that this podcast is for informational purposes only and should not be considered medical advice. It is not intended to replace professional medical care. We are not doctors. We don't claim to be. We are just a couple of nerds who find this information and this research really fascinating, and we want to discuss it, but please keep your medical decisions between you and your doctor and keep us out of it. All right, let's begin. So your brain is made up of a whole bunch of cells, right? Like everything in your body. But the brain cells are special. They kind of look like octopuses, because they have the center, that's the nucleus, but then they also have a bunch of octopus arms coming off, and those are called the dendrites, like a whole bunch of octopus tentacles. And the way that the brain sends messages is one octopus tentacle spits out some chemicals, they kind of float around in the gap for a minute, and then another octopus arm sucks them back up. I don't know if this is like a crazy visual, but hopefully the metaphor makes sense. Those chemicals are neurotransmitters. So neurotransmitters, just any sort of chemical the brain uses for messaging purposes, and it's sending back and forth between those tentacles. You have the sort of common ones that you hear about, that's serotonin, dopamine, norepinephrine, but really anything used for signaling is considered a neurotransmitter. So there's a couple very special ones called GABA and glutamate. And then there's also histamine is a neurotransmitter. Your hormones are a neurotransmitter. So there's a whole bunch of things that can be neurotransmitters. So the life cycle of a neurotransmitter is that the body produces that chemical. So we'll talk about serotonin because that's the one that's commonly talked about with depression, but this applies to like all the other ones too. So your body produces serotonin, packages it up, sends it all the way down that tentacle. It floats around in the space in between, and then it gets reabsorbed, or that's called reuptake is the term there. And so the way that a lot of depression medications work, and in fact a lot of other medications, this is the way that ADHD meds work on dopamine as well. They block that reuptake process, that reabsorption process, so that you have more of that neurotransmitter bioavailable. So maybe, we're mixing metaphors a little bit here, but a good way to think about that is to think about like a bucket. And that bucket has a hole in it. It's supposed to, you don't want it to get completely full, but you're pouring water in. The water being like serotonin. You're pouring liquid serotonin in the bucket. So common depression medications like SSRIs, which are selective serotonin reuptake inhibitors. You can hear it in the name, reuptake inhibitor, right? It's plugging that hole. And so temporarily, instead of water flowing into the bucket and water flowing out of the bucket, you're not having any water flowing out of the bucket. And so the bucket gets more full. Now, you wouldn't want to permanently plug it up. The bucket would overflow eventually, and that's true in the brain. You don't ever want any neurotransmitter to be too high or too low. You can get really, really bad things happening on either end. But that's how they're trying to treat depression, is to plug that hole temporarily just a little bit, maybe make the hole a little smaller, right? And that way the bucket can get more full of serotonin so that you have more serotonin. Sounds good in theory, right? Well, the problem is that it depends where the holes are. And so what clinicians are doing, this is kind of a broad metaphor, but what they're kind of doing is, imagine they can't see the bucket and they're taking a big old piece of tape and they're trying to stick the tape on the hole. Well, maybe it'll work. Maybe they actually get it right on the hole, or maybe they don't. It's kind of like pin the tail on the donkey with a blindfold. And so if that medication doesn't plug up the right hole, then you might not really feel symptom relief. And so just to put in perspective all the different options, all these serotonin reuptake inhibitors, they act on different receptors. But there are 14 different serotonin receptors in the brain. And so some of them are blocking one route, but maybe because of the way that the depression manifests in your brain, this could be based on like genetics, for example, you actually have an issue with a different receptor. And so when you take medication that's blocking one receptor, like it's sticking the tape on the wrong hole, and let's say the other hole is like way too big, that's where all the leaking is coming from, then you're not going to feel a lot better because you're still getting a bunch of leakage out of the other bigger hole. So that's kind of what goes wrong with depression meds. And we do see that reflected to some extent in the statistics. So according to the National Institute of Health, they've done research, they've looked at how antidepressants relieve symptoms. This is like, they looked at the common ones like SSRIs and tricyclics and stuff. And when they subtract out the people who felt symptom relief from placebo effect, they actually found antidepressants improve symptoms in about 20 out of 100 people, which, 20% is not fabulous when you're talking about a group that's at high risk of harm. So I don't at all want to come off like I'm downplaying the importance of antidepressants. They are incredibly important. They are a life-changing invention that has like literally saved so many people, saved so many lives. So I don't want it to come off wrong. Antidepressants are so important. The problem is that they are not high precision enough to cover everybody, right? Like, I don't want to hear that antidepressants help 20 out of 100 people. We want to get to the point where we know how to help 100 out of 100 people. But the fascinating thing is that there is research on different medications like ketamine, and the way that ketamine works is entirely different than SSRIs. So SSRIs and SNRIs are a similar thing, but they're also acting on norepinephrine. But those are predicated on the idea that you need to fix one particular reuptake pathway, right? Or maybe a couple, like the SNRIs kind of target more broadly. And anytime you have more broad targeting, that also comes with more side effects. So specificity is good as long as you are targeting the correct thing. And so that's the idea behind broader medications. Generally more side effects, but also, you're throwing spaghetti at a wall and seeing what sticks. Okay, so similar to how serotonin has a bunch of different receptors like there are 14 different receptors, glutamate also has a bunch of different receptors. And so what ketamine is doing is it is blocking one of those receptors, which is the NMDA receptor. And I'm kind of hand waving here. There's a lot of complex intermediate steps. And if you're interested, we have a link to a video where you can learn about this a little more in depth. But basically blocking the NMDA receptor, which sends more glutamate down to the AMPA receptor. So these are both glutamate receptors, but they do different things. And again, through a long sort of chain of events, when you bind to the AMPA receptor, you increase a chemical called BNDF, brain-derived neurotropic factor. Yeah, BDNF. So BDNF basically stimulates growth of additional dendrites in the brain. So it's making all of those octopus cells in that region grow a bunch more arms. And the idea is that you have a lot of dendrite death with depression, with PTSD, with all these conditions. And so ketamine is helping to regrow all those arms. And so you can imagine it's really hard for the brain to talk to itself, for the different cells to send messages to each other when you don't have enough of those like octopus arms. Those are really important for being able to send messages efficiently. And so ketamine kind of goes around it. It doesn't care if you are deficient in serotonin, because depression symptoms can actually come from imbalances of other neurotransmitters too. You could have low serotonin, you could have low dopamine, you could have low norepinephrine. It can even come from being too high in things, like having high histamine levels can actually cause depressive symptoms as well. And so ketamine is kind of not necessarily caring about like the serotonin pathway in particular. It's just making you regrow a bunch of those dendrites, all the dendritic spines that perhaps died off during depression. And so I think that this really speaks to the fact that there are different types of depression. From the pharmacological side, folks are aware that like there are different types of medications because there are different manifestations of how it's reflected in the brain. And my hope is that someday on like more of the psychology side, that depression will be classified as such, that it's like, okay, if this SSRI didn't work and you don't have low serotonin, you actually have some other imbalance, that it would maybe be called depression type 1, depression type 2, depression type 3, like something that indicates that it's not this sort of homogenous blanket condition. And that's not to say that they've nailed it on the pharmacological side either. I mean, SSRIs are used to treat depression and anxiety and OCD. So certainly there are some precision issues on that end as well. But eventually someday I think that medicine is going to evolve and be a lot more precise. And as we talked about earlier, my high precision autistic brain really, really wants that for people.
And that's a wrap on this bonus episode. We hope you found this deeper dive into depression and ketamine treatment as fascinating, as enlightening as we did. And just a reminder that we are not doctors. We're just nerds and ADHD coaches that are bringing science to our lived experiences and sharing what we learn along the way. And I just want to point out that we're not making any recommendations here. We're just talking about the science and brain chemistry. If you're interested in what any of this means for you, please have a deeper, informed conversation with your doctor, therapist, or psychiatrist. So a big thank you to Tarah for sharing her insights. This is such an important conversation, and we're grateful to be able to bring in these learnings to you. If you enjoyed this episode, don't forget to subscribe, leave us a review, or share it with someone who might find it helpful. We'll be back with more in our next episode, so stay tuned. Take care.